So, as most of the people in this audience are well aware, HCV-related liver disease progresses more quickly in HIV co-infected individuals. And in the Ostrowski lab, we're interested in looking at whether innate immune T cells that are found in the liver may contribute to this progression. So one of the factors that's thought to contribute to HCV disease progression in co-infected individuals is bacterial translocation. This occurs as a result of HIV-related depletion of the gut epithelial lining and downstream depletion of gut mucosal CD4 T cells, which leads to the bacterial translocation of byproducts into the gut and the liver and downstream activation of the immune cells and dysregulation of these cells. It's for this reason that we're interested in looking at Mucosal-Associated Invariant T cells. These T cells have been recently described to respond to bacterial metabolites presented by MHC class I, like molecule MR1. These cells are abundant in the periphery, but they're also abundant in the liver and mucosa, which is why they're of interest in hepatitis C. And they're thought to migrate to tissue sites during infection. So we're also interested in these cells because when they're activated by identifying their bacterial infected target, they can produce both profibrogenic cytokines, including interferon gamma, as well as antifibrogenic cytokines, including interferon gamma, as well as profibrogenic cytokines, including TNF-alpha and IL-17. So in HIV infection, it's been shown that these Mait cells have a reduced peripheral frequency. However, they remain static in the mucosal areas, suggesting that they may be recruited from the periphery to the mucosa. These cells have been found to be highly activated, and they show markers of exhaustion by the expression of TIM3 and PD1. As well, the frequency of these cells that are able to produce cytokines or factors that activate the immune response, be it profibrogenic or antifibrogenic, are reduced in HIV infection. And the accumulation of these non-functional Mait cells increase as infection progresses. So the questions we have in the Ostrowski lab are, is there a change in the peripheral Mait cell frequency in HCV-HIV co-infection? And do these peripheral cells exhibit exhaustion markers? And are they able to produce cytokines? So we looked at this by studying several HCV and HIV infected individuals, both those that were not on treatment, so HIV-infected patients who were treatment naive, HCV-infected patients who were treatment naive, HCV-HIV co-infected patients who were not on HAART therapy or HCV therapy, as well as uninfected controls. And then later we looked at HCV-HIV co-infected individuals who had undetectable HIV viral loads and HCV spontaneous clearers. And so what we wanted to look at is the frequency of these cells, the percentage of these cells that are exhausted, and the percentage of these cells that can produce immune factors, such as interferon gamma. So in order to identify these cells, we used markers such as CD3 that identifies T cells, CD161, and V-alpha 7.2, which is the invariant alpha chain of the invariant T cell receptor expressed on Mait cells. And what we see in healthy individuals is that in the peripheral blood, up to 10% of the cells in the peripheral blood, of the CD3 T cells in the peripheral blood, are Mait cells. And what's of particular interest for hepatitis C is that in the liver, up to 20 to 40% of the CD3 T cells in the liver are Mait cells. So when we looked at the peripheral Mait cell frequencies in patients who were uninfected compared to patients who were HCV infected, HIV infected, and HCV-HIV co-infected, we found that there was a depletion of these cells in all stages of infection. And we found that this was significant for HIV-infected individuals, HCV-infected individuals, and in the Mait cells of HCV-HIV co-infected individuals. So we next wanted to ask the question of, for the detectable Mait cells in these individuals, were they expressing markers of exhaustion? And surface markers of exhaustion suggest that they may be less likely to be able to produce immune factors such as interferon gamma, TNF-alpha, IL-17. And so what we saw compared to healthy controls where there was less exhaustion and more function is that in HCV-HIV co-infected individuals, the Mait cells that we've detected in those individuals were more exhausted, suggesting that they were less functional. As well, these cells can be stimulated with killed E. coli to produce cytokines. And what we saw, we looked at multiple cytokines, but what was most interest to us is that compared to uninfected controls, Mait cells from patients who were HIV, HCV, or HIV-HCV co-infected were less able to produce interferon gamma, which is an antifibrogenic cytokine. We also wanted to look at if these patients were able to either spontaneously clear hepatitis C, or if the HIV was treated using heart therapy, were the Mait cells able to recover, or was the exhaustion reversed in these individuals. And while we didn't see a significant increase in the Mait cells, we did see that they were expressing less markers of exhaustion because there was less surface expression of PD-1. Finally, we wanted to look at whether we could reverse this exhaustion by stimulating these cells or co-culturing these cells with anti-PD-1 antibodies, and we compared those to E. coli treated without anti-PD-1, and what we saw was that we could rescue the amount of interferon gamma being produced in a significant manner. So in summary, we found that Mait cells, which are highly abundant in the liver, are peripherally depleted in HCV and HCV-HIV co-infection, and less able to respond to their microbial metabolites, more exhausted, and less able to produce antifibrogenic cytokines. So it suggests that the impairment of these cells may represent a pathway by which HCV progresses more rapidly in individuals who are HCV-HIV co-infected. And I'd like to thank Ali Fawaz, who was an NCRTP summer student who helped out on this project, and our clinical collaborators who provided the samples, and of course the patient participants in this study.
Great, thanks for a very nice talk. We have some time for a couple of questions.
Thank you, Sonia, for a very nice presentation. I have a couple of questions. Did you look at the liver at all?
So we weren't able to look at liver biopsies. We have, the only samples we had were healthy livers, so it kind of provided a rationale, but we haven't been able to look at in liver biopsies yet.
And was there any correlation between the frequency of Mait cells in the peripheral blood and the degree of fibrosis measured by whatever method available?
There was
or liver disease?
Not at this point. We may look at more patients, but it looked like even early or late in infection, or whether they had a high fibrosis score or low fibrosis score, they were depleted to the same degree. We haven't done enough interferon gamma stimulations to see whether it correlates to the functionality, but in terms of the numbers, there isn't a change, there's a depletion in the numbers, and it seems like it kind of stays static.
Okay, and one last question. Did you look at IL-17?
So we did look at IL-17, and what we saw, and it's in the poster, is that the HCV co-infected individuals, the Mait cells, they all produce the same amount of IL-17 compared to healthy controls. So IL-17, IL-21, TNF-alpha seems the same, and interferon gamma goes down. So it seems like the balance is shifted towards, away from the antifibrogenic interferon gamma, but IL-17 doesn't appear to change.
Okay, thank you.
Oh,
Angela? It's easier for me to ask from here. Thanks for your talk. I was wondering if you looked at any antigen specificity when you were looking at these subsets, or is this like a global phenomenon?
So we just looked with killed E. coli, but we haven't looked with tetramers yet. So, and we haven't looked in, there's multiple bacteria that we could expose them to, so we've only looked in killed E. coli.
So, but is it not alarming that this is not an antigen-specific deficiency, in fact? Is that something you want to discriminate against, or do you expect to see more or less?
I think it'll be related to the amount of microbial translocation. So basically it'll be the more LPS we see, the more soluble CD14 that we see in the plasma, we'll probably see more dysfunction. But I don't think it will be bacteria specific.
so what do you think is going to happen for these patients when they're treated for hepatitis C successfully? Will there be a partial improvement, no improvement, complete recovery?
So we have 6 patients that we looked at after they spontaneously cleared, and we see that the exhaustion markers go down. We've only looked at them at their basically 6 months after they cleared the virus, because we haven't followed them much longer. So the peripheral frequency hasn't gone up yet, but in HIV it looks like the peripheral frequency will go up after, as time progresses. So possibly the frequency will go up. Our indication is that certainly the exhaustion markers go down. So these cells become more functional, and possibly they'll go up in the periphery.
Okay, so thank you very much.